of University of Michigan Sound Support's 2021 Parent Webinar Summer Series. My name is Emma Brooks, and I'm the Sound Support Coordinator for the University of Michigan's Cochlear Implant Program. As you may know, Sound Support is an outreach grant funded by the University of Michigan Department of Otolaryngology and Michigan Medicaid. The grant is designed to provide outreach and support to children with hearing loss throughout Michigan. We've put together this series of webinars for parents due to the great response we've had from past series. If you have any questions today, please send me an email at oto-soundsupportci@med.umich.edu. Today's parent webinar is titled Single-Sided Deafness, Treatment Options. I would like to take this opportunity to introduce our speaker today, Dr. Casey Stack. Casey Stack has worked on various cochlear implant programs for the last 30 years, including Johns Hopkins University Hospital, the University of California, San Francisco, IWK Grace Hospital in Halifax, Nova Scotia, and St. Louis Children's Hospital. She has been a part of the cochlear implant program at the University of Michigan for 15 years and has specialized in pediatric and adult clinical practice. Dr. Stack has presented and published in the area of cochlear implants on the local and national level. At this time, I'll hand it over and Dr. Stack will get us started.
Hi, welcome everybody. Today, as Emma mentioned, I'm going to talk about some treatment options for single-sided deafness. We are seeing more and more patients come into the clinic who are seeking intervention for hearing loss. And so we're going to talk a little bit about the difference between unilateral hearing loss and single-sided deafness, and then discuss the treatment options and why it's important to potentially pursue some intervention for these losses. So first, let's define the difference between unilateral hearing loss and single-sided deafness. Unilateral hearing loss is where one ear is normal and the other ear has hearing loss. But it really could be any type or degree or severity of hearing loss. So it could be a sensory neural hearing loss, a conductive hearing loss, or a mixed hearing loss. And the hearing impaired ear could be anywhere from mild to moderate to severe. For those of you who are familiar with reading how to read an audiogram, but just as a reminder, this is just what we call an audiogram. It's how we plot hearing. And across the top here is where we have low frequency to high frequency. And then on this axis, we have loudness level in decibels. So very, very soft to very, very loud. So this top audiogram shows a right ear, which is these red circles across the top, in the normal range, which is anywhere from 20 decibels and below. And then the X's in blue are the left ear, and you can see that there is a bit of a difference between that right and left ears. And this particular patient has a mild hearing loss in the low frequencies, and then a moderate to severe rising to mild hearing loss in the high frequencies. As compared to the audiogram that you see below it, which is what we call, or what we typically see when we look at an audiogram that depicts single-sided deafness. So single-sided deafness is a subset of unilateral hearing loss, where the patient has normal hearing in one ear, but essentially a profound hearing loss in the other. So no usable hearing typically in the impaired ear. So you can see from the bottom audiogram, again, normal hearing in the right ear because it's below that 20 dB mark, but you've got this significant hearing loss that looks very different from the audiogram on top. So prior to federal mandates that required all babies be screened for hearing loss before leaving their birthing hospital, these hearing losses were typically not identified until the child potentially started kindergarten. And then they were almost always generally ignored, where the professionals would say, well, if you have one good hearing ear, you'll develop normal speech and language, and you should be fine. The same response was given to adults when we would sometimes see them with single-sided deafness, where we would say to them, well, you can't really benefit from traditional amplification in that ear, in that impaired ear. It's too profound. And you have one good ear. You should do okay. But we now know that that's not true. Unilateral hearing losses and single-sided deafness can be really challenging for pediatric and adult patients. And we're going to talk a little bit about why that is. So having hearing in only one ear does have a significant effect on your ability to localize sound due to the head shadow effect and what we call the interoral timing difference or squelch effect. It also has an effect on the loss of your binaural summation, or your brain's ability to interpret sound when using both ears. And all of these things affect your ability to understand speech in the presence of background noise. So let's talk a little bit about why two ears are better than one. So I mentioned the head shadow effect. So what actually is that? The ears are actually very directional, and when sound is presented from any direction, your head actually casts a shadow, and that affects the sound that arrives to each ear. So there's a timing difference and there's an intensity difference when sound is presented from any direction. It takes two ears to be able to localize where that sound is coming from. And sound localization basically depends, or mostly depends, on your central processing of interoral timing, phase, and intensity cues. So without two ears, it makes it very difficult to determine which direction the sound is coming from. And why is this important? Because while low frequency sound can effectively bend around your head and stimulate both your close and your distant ear, high frequency information cannot do that. Your head, or the head, actually gets in the way and blocks the stimulus from the distant ear. And this can result in a dramatic difference in the ability to detect sound when presented in the normal hearing ear as opposed to a deaf ear. It also affects the ability to understand, as we mentioned, speech and noise, depending on where the sound is coming from. I also mentioned the binaural squelch effect. So this can be thought of as a natural noise canceling headphone system that your brain actually controls. So if there are different combinations of speech and noise are presented to each ear, your central auditory system can effectively subtract out some of the noise and really focus on the speech. But it takes two ears for that to happen. If you have normal hearing, you might have some challenge when you're at the mall or you're at a restaurant, but if you have normal hearing, you have a very good ability to be able to understand speech and focus on that without really letting the background noise bother you. You know it's there, but you don't pay that much attention to it. People with hearing loss have a much harder time being able to separate the speech from the background noise. And when you have two ears, you have a better chance of being able to understand that speech in the presence of background noise. And then finally, we talked about that binaural summation, or how your brain uses both ears to interpret the speech. So you don't hear with your ears, you actually hear with your brain. Your ears are just the instrument that deliver the sound to your brain for interpretation. So when sound detection is really poor in one ear as opposed to two, we lose that ability to binaurally summate the sound and interpret what we're hearing. So two ears help you not only localize the sound, but help you in background noise. That's the main function of your two ears. So what are the adverse effects that can happen, and how does that translate to pediatric patients, or if your child happens to have a hearing loss, who are still, their brains are still developing and trying to figure out what they're hearing? We are very concerned about unilateral hearing losses, regardless if it's asymmetric or if it's a single-sided deafness, because these kids have an incredibly difficult time determining where sound is coming from because of what we talked about, the hearing and noise. Hearing from a distance, it's why they might be situated in a classroom a little closer to where the teacher might be standing, but the teacher might be moving around that classroom, and then the distance of that voice gets further away. This can result in some behavioral or social problems, difficulty following direction. You might see distractibility or inattentiveness where you think that might actually be their behavior, but it's actually the fact that they're not hearing it. We also know that children with unilateral hearing losses are at significantly increased risk for educational learning and speech and language difficulties and delay. 24% of children with unilateral hearing losses repeat a grade, compared to 2% of the general population. So if you have unilateral hearing loss, you're 10 times more likely to fail a grade. 59% of children with unilateral hearing loss have some sort of academic or behavior problem, and they are 4 times more likely to have an IEP and twice as likely to have received speech therapy than compared to their children with normal hearing. We also know that a third of those children with unilateral hearing losses will develop vocabulary delays by the time they're 15 to 18 months of age. So they might have a smaller vocabulary, less complex sentence structure. There might be a gap between their language age and their chronological age. So without a sufficient arsenal of listening hours due to these hearing losses, they are at risk for reduced reading rate compared to children with typical hearing. You also might see these behaviors with even a little bit of hearing loss, less energy, fatigue, increased stress level, less social support, distractibility. These are really common. If you talk to teachers or professionals who work with children who are hearing impaired, they're working a lot harder than their normal hearing peers to get through the day, and it's exhausting. You also might see some of these common behaviors with students with unilateral hearing loss. So they might avoid specific environment or activities, especially with large groups due to the difficulty hearing in noise. They might complain of headaches or fatigue, particularly when they are in noisy environments. And as as I just mentioned, they're working really, really hard to hear. They might miss or not understand humor or slang because they just don't pick that up as often as as their normal hearing peers would. They might easily give up, and they might again be very distractible. So what are some of the causes of unilateral hearing loss or single-sided deafness? These are some of the very common causes of hearing loss that can cause hearing loss in both ears. It can just affect one ear. Many times it's what we call congenital or of unknown cause. CMV is another diagnosis or etiology you see with unilateral hearing losses, or cytomegalovirus. Acoustic neuromas are benign tumors that can grow on your hearing nerve that are typically identified as an adult that sometimes get removed and sometimes get monitored. Sometimes it's a sudden hearing loss where we just all of a sudden they have hearing one day and then they lose their hearing in that ear. If you fracture your temporal bone, that can cause a hearing loss. There are different disorders of your circulatory system or different viruses that can cause hearing loss. And also there's different medications that are what we call ototoxic that can also cause hearing loss. So how prevalent is unilateral hearing loss? It's actually 1 in 1,000 newborns are identified with unilateral hearing loss at birth, which is also very similar to babies who are born with bilateral hearing loss. So according to the NIH, 1 in 1,000 babies are born with unilateral hearing loss, and by the time they reach school age, 3 in 100 may have developed some unilateral hearing loss, maybe due to ear infections or other factors that we discussed. It is one of the most prevalent forms of hearing loss, and sadly, the number of children with mild forms of hearing loss are significantly under-identified or underreported in the United States. So what's the good news? Newborn hearing screening, which was federally mandated, has resulted in a greater number of children being identified with unilateral hearing loss and a decrease in age at which they were identified, which is really a great thing. As I said earlier, sometimes these children were not identified with their hearing loss until they hit kindergarten, when they had a hearing screening. So we are identifying these children at younger ages and being able to offer some type of intervention to these parents much, much sooner than we have in the past. What is the recommended medical management of those with unilateral hearing losses? We would always recommend an evaluation with an otolaryngologist or ENT. This can sometimes help determine the cause of the hearing loss. And typically the workup will include not only a physical exam of the ears, but also some sort of imaging, either a CT scan or an MRI. The otolaryngologist may also recommend a genetic consultation to determine if there's some genetic component that's causing the hearing loss. If the hearing loss is caused by middle ear problems like an ear infection, obviously prompt medical management of that is recommended. We also do recommend vision testing. If we identify a hearing loss, we always recommend that the child get their vision tested if they haven't had their vision tested already. Your eyes and ears grow at the same rate in utero, so we want to ensure that the visual system formed normally if the auditory system did not. And then obviously the referral to early intervention. So any services could get set up so that the child has the best chance of starting kindergarten in their mainstream setting. So why is imaging important, either a CT scan or an MRI? There is research that suggests that 40% of children who are identified with significant unilateral hearing loss are due to structural abnormalities of their temporal bone or their cochlea, their inner ear, or their auditory nerve or their cochlear nerve. And so it's important to know if they have a cochlea. If we're putting a hearing aid on an ear where the cochlea may have been malformed, or they potentially don't even have a cochlea, we're really not helping that individual at all. And of course, we always want to stress the importance of a speech and language evaluation for those children who are identified with unilateral hearing loss. We would recommend a baseline speech and language evaluation at the time that the hearing loss is identified, and then the speech pathologist may recommend evaluations at 6 and 12-month intervals to monitor their development and performance. Okay, so what are some of the treatment options for these types of hearing losses? I think it's important to mention this as well, that, before we dive right into all of the options, despite a growing body of research indicating that intervention is important and it does make a difference, there's still in some professional groups remains a lack of consensus on whether or not to treat these losses with a hearing aid or other type of intervention, and when to treat with a hearing aid or some other type of intervention. I feel, and I think hopefully most professionals feel, that knowing what the tools that we have today for not only diagnosing and treating, that they have really nothing to lose. If we don't try, we'll never know if they could benefit from some sort of intervention. And I think for some parents, it's really okay to tell them it's okay to go get a second opinion. If you see a professional and they don't feel it's necessary, or they do, and you're not sure that's really the right thing for your child, I think seeking a second opinion can just provide you with more information. So before we talked about the different interventions, I just very briefly wanted to review very, very briefly how we hear and how we test hearing aids, because it will it will be important when we talk about the treatment options. So we do hear two ways. We hear by air conduction and we hear by bone conduction. Air conduction is what you probably always think of how we hear. Sound enters your, it enters your ear canal from your pinna. It travels down your ear canal, your eardrum. Sorry about that. Your eardrum starts moving. It puts those little ossicles in motion, which sets the foot plate of the stapes in motion. And then the fluid in the middle ear stimulates the hair cells, and the hair cells stimulate the auditory nerve. So we do test by air conduction, and we also test by what we call bone conduction. We hear by the vibration of our skull. So when we test by bone conduction, we are actually bypassing your outer and your middle ear cavity, and we are directly testing the nerve by the vibration of your skull. And to give you an idea of how you hear by bone conduction, it's why even if you plug your ears or you use hearing protection, or you even just put your fingers in your ears, you're only giving yourself about a moderate hearing loss, because you are still hearing by the vibration of your skull. So when we test hearing, we test both ways, because it does help us determine where is that hearing loss coming from. If the hearing loss is coming from the outer or middle ear, that can sometimes be corrected. So when, if your child ever had middle ear fluid, it's this little cavity that's filling up with fluid that is normally air filled, and it can cause a bit of a hearing loss. So when antibiotics are prescribed or the fluid clears up by itself, their hearing returns. If there is a hearing loss in the inner ear, we call that a sensory neural hearing loss, and that is typically not correctable by surgery or medicine, and some sort of intervention is typically recommended. So I did mention, I think a bit earlier, there are 3 types of hearing loss, and we determine the type of hearing loss by comparing their air conduction thresholds when we test their hearing and their bone conduction thresholds, and we identify whether it's a conductive hearing loss, a sensory neural hearing loss, or a combination of the two, which we call a mixed hearing loss. So treatment options for unilateral hearing loss. So this is not SSD. We're just going to talk about that unilateral hearing loss. At the University of Michigan, if a patient has a unilateral hearing loss, we absolutely recommend a hearing aid. And if they have single-sided deafness, where they have a profound hearing loss in their poor ear, we may recommend a hearing aid. But after a trial, we might discuss what other options they have. There are insurances that require a hearing aid trial if a patient is pursuing a different type of intervention. And so sometimes that's why we try a hearing aid on that ear. We will have one of our speech pathologists perform an evaluation to not only determine the need for therapy, but they might also give us an indication of what treatment option might be better given the needs of the child and what's the needs of the family. I think we would all agree that the earlier we intervene, the better. And if we try a hearing aid and it isn't working, then we can absolutely change course and determine if there's another treatment option that would work better. Okay, so we're going to move on to treatment options for single-sided deafness. So these are options for those patients who have normal hearing in one ear and really no measurable hearing or profound hearing loss in their opposite ear. And we're going to break them down into non-surgical options and surgical options. I will stress that at the time that you're watching this video, this list may not be exhaustive, but it just will give you an idea at this point in time when this presentation was recorded, what options might be suggested. Okay, so non-surgical options first. So something that we might try at the very beginning is something called a CROS hearing aid. A A CROS hearing aid is, it's a hearing aid that is, the CROS stands for contralateral routing of the signal. So it looks like two hearing aids, but what is happening is they wear them on their ears that look like two hearing aids, but sound is being picked up on the profound side by a microphone, and it's actually sending the sound to the other device or the better hearing ear to improve sound awareness on the impaired side. So they're not hearing out of that cochlea with that hearing impaired ear. It's just if someone were sitting on, if they had a profound hearing loss in their right ear and they had normal hearing in the left ear, if someone were sitting on their right side, they would not be able to hear them, or they would hear them very poorly. And so this microphone will pick up the sound on their profound ear and send it to a receiver on the better hearing ear, so that if someone were talking to them on their poorer side, they'd actually be able to contribute to the conversation. Some children with anatomical malformations of their pinnas, or what we call microtia, where their pinna is not formed normally, and there are different grades that you see here of microtia. Their pinnas may not be able to support something like a CROS hearing aid. It'd be very difficult to put a hearing aid on an ear where the pinna might be malformed, like a grade 3 or grade 4 microtia malformation. So what options do children have if they have something like a microtia? We might then offer something called a bone conduction device. So a bone conduction device is a system that uses mechanical vibrations to send the sounds from the deafened side or the poor hearing ear, and it will send it by vibrations of the skull to the better hearing ear or the better cochlea. So remember, just a few minutes ago, we talked about how we hear by air conduction from the outer to the middle to the inner ear. We also hear by the vibration of our skull. So we can put a bone conduction device on anywhere on the skull. It can be on the mastoid behind the ear. We could put it at the forehead. We could put it on your teeth, and it is going to vibrate the skull and send it to the better hearing ear. So just like a CROS hearing aid will pick up sound on the dead ear and send it over to the normal hearing ear, a bone conduction device does it the same way, but through a slightly different transducer. So what do they look like? This is just an example of some of the bone conduction devices, non-surgical bone conduction devices that are out there. So here you have something called a Baha device. You've got the Ponto, and then something called the Ad here. So the two pictures that you see at the top, they're wearing what's called a soft band. It just looks like a headband. And the Baha device or the Ponto device just sort of snaps into the headband and rests against the mastoid bone. And so sound is picked up and it vibrates the skull, and they actually are hearing it in their better hearing ear. The Adhere device is just a slightly different device that uses a very, very thin adhesive that you can see right here. So it eliminates the need for a headband, and they will just use the adhesive right behind the ear on the mastoid bone and then snap the transducer onto the adhesive. So let's move on to some surgical options. So how do surgical bone conduction devices differ from non-surgical bone conduction devices? Surgical bone conduction devices, you also might hear the term osteo-integrated devices. So they're bone integrated devices. And they differ in that there is an abutment that is surgically placed in your mastoid bone behind your ear. And then you wear a processor on the outside that will direct connect or to the abutment and also vibrate the skull that way. You don't have to get the surgical bone conduction device. But as you get older, you can imagine that wearing a headband as a 10-year-old or a teenager is not as appealing. And so that's when a family member might choose to go to the surgical component. So this just shows you what the abutments look like. This is the osseo integrated device for what's called the Baja Connect and the Ponto. So these portions are surgically implanted in the mastoid bone right behind your ear. And then they are what we call percutaneous. So the abutment will come through the skin, and then you will snap your sound processor into the abutment. So you don't hear with your bone conduction device unless it is connected. So most people, just like hearing aids, they'll just take off their processor at night when they go to sleep, and then in the morning when they wake up, they'll just snap on their bone conduction processor on the outside. There are also what we call transcutaneous devices. So the percutaneous we talked about will stick through the skin. There's an abutment that comes through the skin, but you have to keep that pretty clean. As you can imagine, you've got this titanium implant coming through your skin. You want to keep it very clean, and the risk of infection is a bit higher. So there are what is called transcutaneous devices, and they use magnets instead of coming through the skin. The osseo integrated device is surgically implanted completely under the skin. There's nothing sticking through the skin, and then the outside processor connects to the internal implanted device via a magnetic connection. So they will just put their processor up, they'll find that magnetic connection, and they hear, and then the same thing at night when they take it off, they don't hear. Cochlear implants have become increasingly prevalent as a treatment option for SSD in adults. It's been happening for decades, and their popularity for the pediatric population has been increasing significantly, I would say, over the past 5 years or so. So it is a treatment option for single-sided deafness, and it is FDA approved for children. So it is an option that we can pursue. There are different cochlear implant systems, and I'm not going to go into the detail about the specific differences of all three, but here's just a picture of the cochlear implant systems for single-sided deafness. There is the internal device that is surgically implanted. A cochlear implant is very different than a bone anchored device. As we've talked about, the bone conduction devices are stimulating typically a normal cochlea by vibration of the skull on the poorer side. A cochlear implant is actually stimulating the impaired ear. So if there is a profound hearing loss in your right ear and there is normal hearing in your left ear, when you're using a bone conduction device, even on the impaired ear, you're stimulating the normal cochlea by the vibration of your skull. With a cochlear implant, that electrode array is actually inserted into the impaired cochlea. And the electrode array is taking the place of those hair cells that are stimulating the auditory nerve because the hair cells are no longer performing their intended function. So this is the main difference between cochlear implants and bone conduction devices for treatment of single-sided deafness. So to determine if someone would qualify for a cochlear implant for SSD, the steps are very similar to what we talked about earlier. We need to diagnose the hearing loss, the degree of hearing loss. We need to look at the imaging to look at the viability of the cochlea, if it could, if an electrode array could be inserted. We typically do a trial with some sort of amplification, very similarly the way we do for bone conduction. We'll seek insurance authorization, and then we'll talk about realistic expectations with the parent and the child. Because as you may know, the cochlear implant does not restore hearing to normal, but it is a prosthetic device that can provide significant hearing to those who are good candidates. So we get a lot of questions sometimes when I see a patient, either an adult or a child. The parents might ask, is it better to go with an osseo integrated device or a bone conduction device versus a cochlear implant when single-sided deafness is diagnosed? And you know, sometimes I think every patient is different, and we need to treat every patient individually and make the best recommendation that we can for that specific child and patient. So every patient that comes in for an evaluation for intervention, when they have SSD, you know, one size I think does not fit all. We have to evaluate them, talk to them about the treatment options. We talk about bone conduction versus a cochlear implant, and try to hopefully give them enough information after we evaluate them. So we will test them. We put them through a specific evaluation, and then once we have the test results, we can help hopefully give the parents enough information so they can make an informed decision to determine which intervention might be best for their child. If there is anatomical malformations to the cochlea, that might lean us toward one specific intervention type over another. I think the other biggest key for making a recommendation to a family to go with an osseo integrated device versus a cochlear implant is the length of deafness in the impaired ear. And this is very similar when we're counseling families of children with bilateral hearing loss who are considering a cochlear implant. Your brain is wired to develop speech and language or auditorily between birth to 3. So if a child comes in and they're, you know, 7, 8, 9, 10 years of age, and they're thinking about intervention for the profound ear, we might steer them toward a bone conduction device because they've had 7 or 10 years of auditory deprivation in that ear. And we know that the longer the ear has been deprived of sound, the less benefit they may receive from a cochlear implant. So if we have a very young child coming in where their deprivation time has been very, very short, we most likely would recommend we might recommend a cochlear implant. We do know that there are some disorders that can occur, like CMV, where it can cause bilateral hearing loss or unilateral hearing loss. If the CMV has caused bilateral or unilateral hearing loss, sometimes we'll recommend a cochlear implant because we are concerned about the other ear hearing dropping, which can happen with CMV. So again, one size doesn't fit all, and we do try to look at the etiology and the imaging and the length of deafness and try to come up with an appropriate plan. So lots of things we talked about already. Factors we consider. So residual hearing in the ear to be implanted, speech recognition. How much did they understand anything with the hearing aid in that impaired ear when we put a hearing aid on that ear? We talked about the diagnosis, their speech and language skills. Obviously, our big concern is hoping, wanting them to achieve their, you know, the best academic performance they can. And how do we go about doing that? I don't think waiting for the better ear to drop is a good treatment option, and I would hope that most professionals would agree with that. If there is a hearing loss in an ear, we should treat it. We should focus on it and provide the best listening environment that we can for these kids. We don't worry about insurance because hopefully that if you're watching this and you're not at Michigan Medicine, there are insurance pre-authorization letters that everybody has to send to get intervention covered, and we work with the insurance companies and provide what are called letters of medical necessity. Is it medically necessary that this child receive this type of intervention to succeed? And we put supporting evidence in, sometimes it's the test results to help the insurance companies understand why we're recommending one intervention over the other. I think regardless of what treatment option is recommended, the goal obviously is to help the child succeed in the classroom. So what we need to do in that classroom is to reduce the amount of background noise. We could do a whole talk on, you know, the levels, the varying noise levels in a typical classroom, and it's really, really noisy. So despite what intervention is chosen, or if even no intervention is chosen, an FM system or some type of remote microphone technology worn by the teacher would still be strongly recommended. We can fit FMs in conjunction with some of this technology, or remote microphone technology, and we would strongly recommend that that be used. So in summary, I think treatment options in hearing loss with children with unilateral hearing losses or asymmetric hearing losses in SSD has changed. I think we need to think outside the box when we treat these children. We know that unilateral hearing losses pose great problems for listeners, especially in the classroom. You know, intervention has changed and is evolving. I think as professionals, we need to be increasingly proactive to provide families with the most up-to-date information and what their options are. I think if your child was not a candidate for a specific technology previously, just know that it does change. Candidacy changes, technology changes, it gets better. And so if you were not, or you or your child was not a candidate previously, you can always come back or go back for a second or third evaluation to see what new technology is available, because there always might be something new that has come out. I've put my email address there just in case you have questions, and you are more than welcome to email me. And I thank you for your attention.
Thank you, Casey. If you do have any questions about this webinar, you can either email Casey or you can email myself at oto-soundsupportci@med.umich.edu. Again, I just want to thank Dr. Sack for taking the time to present today, and for those of you that have watched today's webinar. With that, we will conclude today's webinar. Thank you again for watching.